Yeah, so we're going to be talking about joint pain. So you'll come across this in your musculoskeletal rheumatology rotation, and we're just going to be going through some of the core conditions in a case-based format. So if you want to, you can join the Slido. I'll give you just a minute to join, and I'll join that as well. And you can ask questions using that as well throughout if you have anything that you want to clarify. Okay. Okay, so let's get started. We've got a 60-year-old patient and she has a painful right knee and painful hands. So just list any immediate differentials, anything that you think it could be, anything at all that you might have heard of. Okay, we've got a few. Yeah, that all sounds good. Okay, so it sounds like some of you might have already started your rotation because you've got some more niche ones on there. Here's a sort of broad list of some of your core conditions. So I saw a bit of osteoarthritis, rheumatoid arthritis, and some of the more specific ones as well. This is just like a more cohesive list of ones that we're going to talk about today. Um, so in order to narrow down your differentials, what kind of questions might you ask? We're just going to go through that now. So we're going to start with a presenting complaint as you always would. So they might complain of pain, but there's also quite a few other symptoms that people might present with, not just pain. So we've got stiffness, swelling, erythema, which is redness or warmth around a joint, weakness using their joints. They might not be able to do their daily activities of living, and they might have extra-articular symptoms, which can be weird and wonderful. You'd come across them in your systems review. And where possible, try and use Socrates because it fits quite nicely. So we're just going to do that now. So using Socrates, you start off with the site of pain or whatever it is. Usually, you're going to split up joint pain into inflammatory and non-inflammatory causes. So, degenerative and inflammatory. Usually, for degenerative causes, it's quite asymmetric because it's whatever joint you use the most. For example, if you're right-handed, your right hand might have more joint pain if it's a degenerative cause. Whereas inflammatory is more of a systemic pathophysiology, so you're going to see symmetric pathology. As well as that, for the same reasons, you've got small joints more affected in inflammatory pain versus the weight-bearing joints in sort of things like osteoarthritis, because that's where you get more damage. And then for some of the other causes of joint pain, you might have heard of these words monoarthritis, oligo, and poly. So mono would mean only one joint is affected. You usually see that in sepsis or, septic arthritis, gout, pseudo gout, or trauma, because obviously you're only hitting one joint. Oligo would mean one or more, and that covers a broader range of some of the HLA B27 arthritis. Polyarthritis means sort of two plus, which is usually the inflammatory disorders again. You're next gonna talk about onset or duration. So you can look at how suddenly did the joint pain come on. If it's quite sudden, it usually is something inflammatory or obviously trauma. Versus for chronic inflammatory conditions or degenerative conditions, they'll talk about It's been gradually getting worse. I don't quite remember when it started, maybe a few years ago. And obviously, if you can pin down an inciting incident of when the pain came on, for example, I bent down while I was gardening and I felt something in my back pop, something like that would point towards trauma. So now we've got some sort of spreads of disease. So we're gonna try and figure out how to do this. But if you can look on your Slido and just try and figure out which diagnosis would match with each of these. So I'll move on to the next slide, but just I'll give you a few minutes to look at this. I'll give you 1 minute and then you can type in what you think would be each of these diagnoses. And this one would apply to the blue and the red. So just have a think about that. Okay, so if you have any ideas, you can type them down. And if you want me to go back, let me know. I'll go back briefly, just so we can talk about it. Oh, we've got it. Okay. Yellow, osteo, blue, psoriatic. Yeah, exactly. That's right. Um, let's go back and look at it. Okay, so yellow osteoarthritis, because we talked about how it's usually the weight-bearing joints. So that would be more of the DIP joints. You can see the hip here is being highlighted, shoulder joint, cervical is very important. Asymmetric pattern, so depending on the person's dominance, that might be the side that's more affected. Stiffness with activity, so we haven't quite talked about that yet. But you definitely need to ask about what makes the pain worse. So because this is degenerative, you're gonna it makes sense that activity would make the pain worse and stiffness as well would become worse. We'll talk about some of these X-ray changes as well in a bit. This one, psoriatic arthritis, this is a giveaway, some of the extra-articular manifestations, but psoriasis, you don't always see this, but it definitely is a good clue. Ankylosing, we'll cover these key terms as well in a bit, but some of these more systemic symptoms versus here you've just got a lot of joint symptoms. So this is a giveaway of something inflammatory going on. Definitely morning stiffness, it's worse when you've not moved it in a while. Some of the more proximal joints being affected, like PIP joints, symmetric because we said it's systemic, and some signs of something autoimmune going on with erosions and destructive lesions. So that's good. So now we can talk about characters. We've done site, onset, character. Here are some descriptions of what people might say. So let's go through it. So dull, boring pain. So it feels very deep into the bone is a sign of something is probably going on very deep inside the bone. Normally sounds like something that it could be a red flag symptom. So these are some of the conditions you'd be quite concerned about. Osteomyelitis, necrosis, some sort of malignancy. A sharp and stabbing pain is sort of similar to acute onset pain. You might think of a fracture or some sort of trauma causing that, possibly a pulled tendon, something like that. Shooting pain normally describes, rather than joint pain, nerve pain. It's quite a large area can be affected, like the all down the back of my legs hurts. That might follow the distribution of the sciatic nerve. So you might think of inflammation of a nerve itself. Unremitting, meaning nothing makes it better, is always there, is can be fibromyalgia. Because usually with some of these other diagnoses, you will see it gets better as the day goes on, or it gets better if I rest it. But if they're saying I've got pain all the time, it might be fibromyalgia. Out of proportion to stimulus, that's kind of like a buzz phrase that you might see in SBAs, and it could be compartment syndrome. So especially if you're seeing post-surgery, after they've been in some sort of constricted device, like a cast or something like that, and then just touching the limb makes it hurt a lot. It's out of proportion to the stimulus, might suggest compartment syndrome. And don't forget DVTs as well. They might just say leg pain, so that's pretty broad, and it could involve DVT as well. Um, and if they're saying they feel stiffness rather than pain, that again points to potentially something inflammatory. So some of these, someone mentioned it before, polymyositis, dermatomyositis. Next, we can talk about radiation. So we already talked about it a bit, but inflammatory pain, you've got more local. Oh, okay, it's cutting out a bit. Let me see if I can change my Wi-Fi. Okay, so we can talk about radiation of pain. So if it's more localized, these are some of the things we can talk. That should be rheumatoid, but anyway, trauma, gout, sepsis, monoarthritis. If the pain migrates or moves to the surrounding areas, it could be referred pain. So just think about the path of the nerves. So, for example, you might have shoulder pain and some sort of gastric problem. Um, so think about the pathway of the nerves or the path that the tendon or ligament follows. Migratory pain, that's another buzzword, especially in all of these conditions. So rheumatic fever, Lyme disease, lupus. You might see some of these, this specific word being used. Um, for nerve or dermatome specific, so especially if we're talking about something like shingles or a really specific dermatome being followed, these are some of the diagnoses that you might want to think about. Okay. And finally, associated symptoms. This is really important for the inflammatory arthritis. These more systemic or constitutional symptoms like fever, weight loss, some of these that we'll cover in a bit, all point away from osteoarthritis because usually the only thing you see is joint pain in osteo. We talked about this, but time and duration. So especially if they're saying they have morning pain or stiffness, that gets better, say after 30 minutes, that suggests rheumatoid, versus they've been on their feet the whole day and then their knee hurts at the end of the day, that sounds more like osteo. Exacerbating or relieving factors. So you want to ask them what makes their pain or stiffness better or worse. Does moving it around work? So, for example, in rheumatoid, moving it around does help because of the passage of synovial fluid through the joints, helps distribute whatever inflammatory markers there are causing the joint problems. Versus an osteo, that's not really going to have an impact. Morning, night, we've discussed medication. So there's certain medications that will cause joint pain directly or make joint pain better, like NSAIDs, especially in inflammatory causes. NSAIDs are going to be really helpful. And then severity, get them to rank it from 0 to 10. If it's really, really high, it's probably some sort of red flag cause. If it's low, possibly fibromyalgia. So that's another important one not to forget. Uh, okay, so we've got some extra articular symptoms. So if you can put it in the chat or whatever. I hope you can hear me, but um, here are some signs, and there's a few diagnoses associated with each one. So if we start with uveitis, does anyone have any ideas of any causes of joint pain where you might also see uveitis, especially anterior uveitis? Yeah, that's good. Anything else? Yeah, exactly. That's the one I was after, angst so angst sarcoidosis. For reactive arthritis, usually they say conjunctivitis, but you can also have uveitis as well. What about Gottron's papules? I've got some pictures because you hear these words all the time, but you need to go and look them up as well. Any ideas? So this one's pretty specific to dermatomyositis. You only really see it's kind of like a reddish broken skin appearance, which I'll show you later on. Livedo reticularis, you might have heard of. There's quite a few different things that could be going on there, but any ideas? It is a pretty tricky one, but you might have seen it in other irritations. So antiphospholipid syndrome, um, you get these, it's kind of like a splotchy appearance of the skin. And specific to joint pain, you've got polyarthritis nodosa. Raynaud's, that's quite a good one to know for SBAs. Yeah, that's good. So scleroderma. And I might not have written it on here, but SLE as well. Sometimes you get Raynaud's. But that's good. Scleroderma. So Crest syndrome or systemic sclerosis, you get Raynaud's. Peripheral neuropathy. There's a whole sort of branch of causes of joint pain that you might see peripheral neuropathy in. Yeah, exactly, vasculitis and Sjogren's syndrome as well. What about oral ulcers? That's another kind of one-word diagnosis that you might see. SLE is a good one. Reactive, you get it, yeah. But there's one other one. It begins with B. Yeah, exactly, Behçet's. So that's pretty pathognomonic for Behçet's as well as reactive, we said. Pulmonary hypertension, this one might be a little bit trickier. Not quite, not quite pseudo-gout. If we think about the pathophysiology for this would be something that causes sclerosis, pretty widespread sclerosis of the art, including of arterioles. Yeah, exactly. Not scleroderma, systemic sclerosis, yeah. So that's exactly what it is. Sclerosis can affect anywhere. So if it affects pulmonary artery, you get pulmonary hypertension as well. So that's an important thing to look out for. Here's some pictures of some of the signs. They may well show you a picture instead of using a word to describe it. Um, any idea of what this first one is? I hope you can see my mouse. Um, So it's kind of like a scaly patch affecting the extensor surfaces. Any ideas? Yeah, this is one of the tricky ones to be fair. It's got Trohn's papules, so dermatomyositis. So this is what it looks like. Um, Kind of similar to psoriatic plaques, but psoriatic are very silvery and scaly. Um, and these are called like mechanic's hands as well. So really cracked erythematous skin is what you're looking for. What about this next one on the legs? They're circled here. Yeah, exactly. Erythema nodosum. And any idea of the diagnosis for this one? We talked about it before. Could be, that's a good one. Yeah, you've got IBD associated arthritis as well. Sarcoid is what I noted, but all of what you've said is correct. What about this one? I'm sorry about this picture, but it's a good one. Quite nodular and surrounding the joints themselves. That's a good guess, but it's not like a normal location for gouty tophi. These are rheumatoid nodules. So also think about the location. Gouty tophi, you'd more sort of, if you're thinking of very stereotypically, like behind the ears, elbows is where you'd see those. On the feet is it's more sort of could be rheumatoid, could be gouty as well. What about this? Yeah, brilliant. So mala rash, butterfly rash, lupus. What about this one? I've seen this exact picture before, um, in either the formative or the summative. That is a good guess, but that is more of a skin change, calcinosis. If you're looking closely at the nails, what can you see? Exactly. And any idea of what pitting nails would be associated with? Yeah, brilliant. So you can either have onycholysis, which is like a fungally kind of lifting of the nails, or also nail pitting as well, is associated with psoriatic arthritis. What about this rash? So this is a bit of a difficult one. And I can give you a clue, it's like an infectious cause of joint pain. Very close. This is why I put it in because there's so many erythema somethings. This is another one of them. This is erythema marginatum. So how I remember it is it's like you can see the margins of the like bullseye rash. So that's what they call it. Bullseye rash, erythema marginatum, all due to Lyme disease. So tick bite, someone who's been traveling like in America, gone to the mountain somewhere, bit by a tick, have a fever and joint pain, think Lyme disease. And here is a summary of some of the skin changes that you might see. So there's a few that we haven't talked about. We've talked about lupus. Discoid lupus can look pretty similar to this bullseye rash, but think about some of the other extra-articular manifestations of lupus. Rheumatoid nodules, think about location, think about onset to differentiate this from gout. Psoriasis is quite self-explanatory usually. Dermatomyositis, so think about polymyositis plus skin changes, you would probably have dermatomyositis. some of the more sort of like genital region skin changes or just really rough rashes in general. Think reactive arthritis, especially if you can pinpoint the preceding infection. It's also called Reiter syndrome, but I've usually seen it as reactive more recently. For systemic sclerosis, like someone said, I think Crest syndrome, so all of the manifestations of that there. Sarcoid is this round, usually on the shins, is erythema nodosum, would be sarcoid, or the various other things we've talked about. And then for each infection that it could be, so some sort of septic arthritis, think about some of the skin changes you might see there. So for example, Neisseria, so some sort of gonococcal infection, you might see some pustules or like palpable purpura. But once you do IND, you might feel more familiar with these. But this is just something to look out for in SBAs. Any questions so far about that, or are we good to go? Let me just have a quick look. And don't worry if you can't copy everything down because we will release the recording for this as well. So you can go back and look at it as well if you want to take any notes of anything. What's the difference between infectious and reactive? So when I say infectious, I mean like septic arthritis is what I think I mean. So reactive, we will get onto the pathophysiology, but just briefly, reactive is actually a sterile arthritis. So you've not actually got any, on our curriculum map, we haven't got sarcoid or dermatomyositis. Does this need to be covered? So it is, I've definitely seen SBAs on both of these conditions, especially on PassMed. So I think it's something that you're not going to need to know the full pathophysiology of, and I definitely haven't paid close attention to that, but they're good differentials to be able to diagnose, and they're not hard to pick up either. So um, sarcoid you almost never have to diagnose because there's so many different manifestations. But if you see certain buzzwords, like erythema nodosum, knowing that it's not the rest of these things would be good. It would be handy. And dermatomyositis, polymyositis, we definitely had teaching on those. So I would go back and check the curriculum map if not in module B, it might be in a different module. But they're definitely good ones to know about. Maybe not too in depth as much as rheumatoid or osteo. So let's keep going. Okay, so exacerbating relieving factors. We've talked in depth about these. I did talk about this pathophysiology of why rheumatoid improves with movement. We're moving away some of the, if you think of it as moving away some of the inflammatory, like cytokines or whatever it is that's causing the destruction of the joint. That's why it feels better with movement. Some people might say, like, if they drink alcohol, their joint hurts worse. That sounds a lot like gout. And we've talked about severity as well. Okay. So now we've got some questions. So just try and differentiate whether this is inflammatory or non-inflammatory joint pain. So if you want to join, I'll give you a moment to do that. Okay. So here we go. Morning stiffness that lasts more than 30 minutes. What do we think? Give you 10 more seconds. Brilliant. Everyone said inflammatory. That's good. And if you need any clarification, please let me know. I'll just, if we get it all correct, then I'm going to assume that you're happy with it. Worsens with activity, improves with rest. I'll give you 10 more seconds. Okay, great. Non-inflammatory. Pain in mostly weight-bearing joints. Brilliant, non-inflammatory. Sudden onset of joint pain. This one is a bit of a trick question, I will say. Yeah, I'd lean towards inflammatory, but it can be non-inflammatory if we're including stuff like trauma. So could be either. But just read the question stem very carefully. Bilateral and symmetrical pain. Good, because we're talking about something systemic is going on. Constitutional symptoms. Amazing, inflammatory. They respond pretty well to using NSAIDs or steroids. Brilliant, inflammatory. So that's a bit of foreshadowing for management as well, but that tends to be the management for inflammatory pain. Okay, so here is a summary of pretty classic presentation in questions for inflammatory versus non-inflammatory. This is a really good way of going about SBAs. If you can look at it from like a Socrates perspective and halve the answer options, you'll be good to go. So look back at the recording or take a screenshot or whatever. This is a good summary. Okay. So now we can move on to asking them about their past medical history. So there's some conditions that you definitely want to be aware of that might point to certain diagnoses. So one good one is diabetes, or actually, I've already said it, but diabetes. But if you can put in the chat some diagnoses in past medical history that would point to some specific causes of joint pain. I'll put up diabetes here. But you'd be thinking certain causes of osteomyelitis or Charcot joint. Osteoporosis, that's good. So osteoporosis, you might be thinking some sort of fracture, some sort of like pathological fracture in somewhere that would be a weak bone. IBDs is a good one for IBD associated arthritis or any sort of they might be immunosuppressed, they might be more likely to get some sort of septic arthritis or reactive arthritis from that. So Staph aureus osteomyelitis. So the reason someone might be more, again, this ties into being immunosuppressed. So someone who's likely to get to have some sort of recent surgery or something on their joint. They might contract Staph aureus because that can be a commensal on the skin. That might be introduced into the joint and cause osteomyelitis. Those are all good ones. So celiac disease, malabsorptive, IBDs, you might have a vitamin D deficiency from that, and as a result have like weak bone, and that can cause fractures. Recent stroke is a good one because they're more at risk of falls, and that right there is a reason for being more susceptible to trauma. Tuberculosis is a good one. If it infects your spine, it can cause something called Pott's disease. So think about someone who's maybe traveled in from a country that has TB endemic and they have back pain, and they might have some rest symptoms as well. Could be Pott's disease. Sickle cell disease has a very specific cause of osteomyelitis that they're more at risk of. Does anyone know if you've done your infectious disease rotation? This is a good SBA. Brilliant, yeah, salmonella. So specifically for people with um, sickle cell disease, they're more at risk of anything that is sort of encapsulated. So salmonella is a good one. And also the sickle crises as well. So it's the sickled cells can sequester in the joint spaces and cause a lot of pain because of ischemia. So that causes joint pain as well. Previous falls or surgery. So think about um, the cause of that previous fall or surgery. How is their bone health doing? Do they have any underlying joint instability, as well as prosthetics? So the problem with prosthetics is you need to have sort of a low threshold for thinking about infection, especially if that was done recently. And it always you need to think about it coming out or calling for help very early on. Okay, so now we're gonna talk about, oops, some of the genetic markers for certain conditions. So we'll start off with angst or I'll wait for you to join if you want to. And we're good to go. Okay, ankylosing spondylitis. So sometimes they give you these genetic markers, and that's a good way of immediately getting rid of certain diagnoses. And there's a few odd markers that I've thrown in here that you might not need to know about, but they're good to be aware of. Okay, so angst HLA B27. So that's the reason I put it in. There's so many HLAs that it can get really confusing. But B27 is what ties all of those seronegative arthropathies together. And we'll go through the other ones as well. Rheumatoid. A very tricky one. Okay, so rheumatoid is a seropositive arthritis. So you've got seropositive and seronegative. Um, Seronegative would be all of the HLA B27 positives. So rheumatoid does not fall under that. It's actually DR4. DR2 is associated with a different one we'll talk about in a bit, but DR4 is the one you're thinking of for rheumatoid. So, and also think about the difference between these genetic markers and like serology markers. So anti-CCP, rheumatoid factor, those aren't genes, those are markers that are in your blood. So just think about the difference between those two things. So DR4 for rheumatoid. Systemic sclerosis. SCL70. So it kind of is in the name, like that's how I pretty much remember it is sclerosis SCL70. And it's not a seronegative arthropathy. SLE. And there can be a bit of overlap between some of these markers as well. So it's possible that people are positive for more than one. So this one is DR2. So DR4 rheumatoid typically, DR2 SLE. Okay, now these are the more tricky ones, but Marfan syndrome. So think long limbs. FBN one. So the problem here is a defect with fibrillin. Um, so that's kind of in the name FBN. So that possibly might help you remember the pathophysiology for Marfan's, and it affects quite a few different systems. So it could come up in like your resp rotations or something as well. Ehlers-Danlos. Brilliant. So this is a problem with collagen synthesis. So col3A1 contributes to the making of the precursors for collagen. So that's it. So try and think about the difference between Marfan's and Ehlers-Danlos, both of which can cause joint pain or hypermobility, those kind of symptoms in a like a young male normally. So here's the summary of the markers. And like I said, people can be positive for more than one. These four are definitely good ones to know. These ones are handy if you want to know more about them. So drug history, we mentioned a bit earlier that there's certain drugs that put you more at risk of joint pain or can directly cause joint pain. And some of these you might actually have to do some drug counseling about in your OSCEs. Definitely these top two. So statins, one of the side effects would be myositis. Fibrates are another type of lipid lowering drug, both of which, especially if given together, can cause myositis, which is inflammation of muscle cells. Corticosteroids, there's a whole host of problems they can cause, so osteoporosis. So you need to be giving bisphosphonates with corticosteroids, as well as PPIs as well. Avascular necrosis, so there's some bones in the body that have sort of a strange blood supply, um, especially the hip or sort of some of the bones of your hand. Think about avascular necrosis if there's joint pain or pain in either of those regions, if someone's been on corticosteroids for a long time. And myopathy in general, it just can cause antibiotics, anti-malarials, um, can precipitate this sort of joint pain. Um, Drug-induced lupus. So you've got your systemic lupus as well as drug-induced, and um, the acronym for that is SHIP. Some of the drugs that can cause drug-induced lupus. Quinolones, for example, ciprofloxacin. This is a really good SBA one that I've seen on PassMed as well. Could come up if you see someone who's just been started on Cipro and they have like pain in the back of their ankle or foot, could be Achilles tendon rupture, but it can also just cause myopathy in general. So these are some of the drugs to be aware of. And finally, social history. So think about the impact. Well, these are just really good questions to ask in an OSCE setting, because they show that you've really like taken in some of the questions that an actual clinician might ask. So think about assessing functional impact. Does the pain affect your ADLs? For example, are you able to fasten your button, brush your teeth, open jars, try and figure out how this impacts the person. Are they able to climb stairs, get up from the chair? That helps you distinguish what type of muscles are being affected, like proximal muscles, or is it more distal muscles or joints? Hand dominance, that's one I've heard on my ortho rotation. They care a lot about what hand does the patient usually use. And this is really handy if you need to identify repetitive stress injuries like carpal tunnel syndrome, um, or even just to figure out the mechanism of the injury. That's a good one to know. And diet, this is more for gout, trying to figure out do they drink a lot of alcohol? Anything that has lots of purines in it can cause a buildup of uric acid. So that's another thing that's helpful in MSK history. So now this sort of summarizes how you should kind of look at it in your head. You've got arthritis, which can be split into inflammatory or non-inflammatory. Seropositive, like I said, refers to anything, ignore these four, but anything that's positive for rheumatoid factor. Some of these can be, but they're not routinely in like SBA land positive rheumatoid factor. Um, that doesn't, it's not talking about all inflammatory markers, it's only referring to rheumatoid factor. Seronegative would be anything where you never see rheumatoid factor, but the thing they all have in common is they're normally positive for HLA-B27. And then you can have infectious, so that would be like septic arthritis, for example, and crystal-induced gout versus pseudo-gout. So that's a nice table I found that differentiates the different causes. So in terms of diagnostic workup, our patient is reporting stiffness that lasts about 30 minutes in the morning. So what diagnostic tests would you like to consider? So think broad first and then go into more specific. Okay. So we've got some really good keywords here. So if we're talking systematically, I can move on to the next slide, which I've done. Okay, so the first thing that you want to start off by always saying is obviously your bedside investigations. So that would be your examination. Say we've done the examination already, next thing you want to do is do bloods. So I saw some things, ESR, CRP were mentioned. And here's a comprehensive list of things that you might want to order. Rheumatoid factor, is this a seropositive arthritis? Anti-CCP really is more specific to rheumatoid arthritis. White blood cells in the full blood count, is it high? Do they have some sort of systemic infection going on? ANA, are they positive for any sort of vasculitis? Anti-dsDNA, lupus, uric acid. So serum uric acid can also be high in gout, and that helps you distinguish between gout and pseudo-gout, for example. Calcium and phosphate might be strange for either sort of pseudo-gout, kidney disease, something like that. HLA-B27 we said is a genetic test, so seronegative. Vitamin D and calcium for osteoporosis. And TFTs as well is important because they also thyroid hormone has a lot of metabolic action, and that can contribute to like problems with muscle health as well. So think about all of those. Blood cultures as well for distinguishing between septic arthritis and reactive. Because like I said before, reactive would be sterile. You're not going to see any organisms growing there. Versus septic, you would tend to see something growing. You could order imaging, which is really helpful, and we'll talk about it in a bit and look at some of the signs. And you could do a joint aspiration, which is really helpful. Look at the joint itself and see what it's sort of what things are growing there. Blood culture is sort of what's growing in your body. If you've got some other infection going on, it might not be as helpful. So we've got an X-ray here. So just look at it in whatever way you've been taught so far. You might have been taught like ripe and then look at each joint, trace around the contours, try and find any fractures. Any ideas of what the diagnosis is? And you can put it in the chat or directly to me if you want, if you've got any ideas. That's a good one, rheumatoid. osteo. It's going to be either rheumatoid or osteo. So it is osteo in this case because the first thing you can see is a clear loss of joint space. All of the bones look really fused together. And the best way to identify this is by looking at loads of normal X-rays, especially sort of here, here, here. You can see a clear loss of joint space, which is pretty diagnostic for osteo. Next thing you might find really challenging to see, but is all right in this one is osteophytes. They're like little bony spurs that come off. I don't know if you can see this one here as well. So that's osteo. Subchondral sclerosis, just sort of more white or like yeah, a lot of white space in the where the joints are meeting, and subchondral cysts. Also sort of spurs that are coming off of the side of bones, changing the shape of the bones to what they usually might be. And that's more a reaction to the destruction of bone that's happening in that area. The bone is now being told to grow more bone in that area that's been destroyed. So these are some of this is a good mnemonic you might have heard for osteoarthritis. So loss. So here's a summary slide for osteoarthritis. We've talked about it a fair bit now. We've talked about how the pain gets a lot worse with use and it improves with rest. You've got unilateral symptoms and you've not really got anything systemic going on, so you're not going to see much in the way of extra-articular. The etiology is wear and tear, so it's a problem that becomes more common with aging. Wear and tear of the cartilage that lines the articular surface. So you're going to get exposed subchondral bone, and that's why you're seeing sclerosis and cysts forming. You get osteophyte formation, especially in the DIP and the PIP. If it's the DIP, it's the Heberdens. PIP, Bouchard. So think about it like HB, like a pencil from distal to proximal. So those are the names of some of the signs you might see. The diagnosis is usually clinical. There's nothing that, I mean, an X-ray is quite helpful, but some of these signs might only show up really later on. But this is the clinical picture. Management, always go stepwise, so non-pharmacological weight loss, that's helpful for like weight-bearing joints, weight loss, you're putting less stress on the joints. Physio could be helpful, and exercise. And also another thing to mention for weight loss is try and figure out if your patient actually is what the BMI of the patient, make it specific to their treatment. Pharmacological, there's not anything too interesting, but start off with topical NSAIDs, some sort of gel, ibuprofen gel, oral NSAIDs, and always remember to cover with a PPI because of risk of ulcers. In acute flares, you can do intra-articular steroid joints, that's third line, and fourth line is joint replacement, which you might see like a hip replacement or a knee replacement, something like that. So question, is the thumb PIP subluxed? So in this X-ray, I think it's just the way that it's sitting, but subluxation is more specific to some other type of arthropathies that we're going to come across. You might see it if there's really severe joint destruction. I think this is just the way the X-ray is positioned. But I can't be 100%. It's a good question. So here we have a different X-ray. Any idea of what this might be? Rheumatoid arthritis, good. It is rheumatoid. So usually you get a lot of soft tissue swelling because we have a lot of inflammation, edema going on in the spots where there's autoimmune processes going on. So soft tissue swelling can be prominent. You can see, so also don't forget to not just look at the bone, look at the skin as well. I hope it's clear on here, but you can see they look all of the digits look quite swollen. periarticular osteoporosis. It can be another thing that's sort of just a bunch of words, but if you look at the joints themselves, you can see the lucency is pretty low around some of the joints. That's again showing you there's some sort of destruction going on. And that typically is autoimmune. It's not something like wear and tear can cause, because your rate of replacement of bone tends to keep up in osteo, whereas rheumatoid, you've got more damage being done than is being recovered. So that's periarticular osteoporosis. Absent osteophytes. So the theory here is that there's no, I should get rid of that. The theory here is that because there's lots of inflammation, there's no need for osteophytes to be coming in. Then they're not attracted to these areas to replace the damage that's being done. So that's why you see that in osteo, because there's nothing actually inflammatory going on there. Whereas in rheumatoid, you've got loads of other markers like flooding to these areas. So osteophytes aren't going to be there. Next thing is you get deformities. So you can see that it's pretty bad. All of these, I might call them subluxed, yes. They're not like exactly in their joint capsule. And again, that's just a testament to how much damage is being done and how quickly as well. Erosions, again, you've got autoimmune destruction, subluxations. Yeah, so this is more classically seen in rheumatoid, although obviously anyone can sublux anything. So we're more talking like if this is say like a 40-year-old who's never had any treatment for rheumatoid arthritis and she's got some sort of deformed joint, could be subluxed on X-ray, that you're probably thinking rheumatoid arthritis. So in the thumb, is it a swan neck deformity? Yeah, that's a good point. So exactly that. You've got like flexion of the DIP, so swan neck deformity. Some other things you might notice is like squaring of the contour of the distal side is another thing you might see. So rheumatoid, you've got your pain and stiffness that's worse in the morning, but it gets better with use as you spread that synovial fluid around. You've got bilateral symptoms because something systemic is going on. You've got these deformities here, so swan neck and boutonnières. So have a look at some pictures. I'm sorry I didn't include them here, but swan neck you saw, boutonnières. Constitutional symptoms, you've got something autoimmune going on, so people might have fatigue, weight loss. The etiology here is, you don't need to know it in this much detail, but I have seen questions on what's actually going on in rheumatoid. But the problem is inflammation of the synovial. And that causes formation of granulation tissue, which is a marker of healing. And that granulation tissue then can cause more destruction of the cartilage as well as ankylosis, which is like fusion. And that is what causes the symptoms of joint pain and rheumatoid arthritis. So the diagnosis here is rheumatoid factor. It's pretty non-specific, but then more specific is anti-CCP. And then CRP and ESR might be high as well. But obviously order all of your other classic things, FBCUs and E's, but remember to explain why you're doing that. It's more to exclude other diagnoses in this case. In terms of imaging, anything is pretty helpful. X-ray is standard, ultrasound for some of those smaller hand joints is helpful, or MRI as well. And then management, you might have heard of you can monitor using the CRP, but you might have heard of the DAS-28 score, which is like a patient questionnaire thinking about how it affects their activities of daily living is helpful to track how they're doing. In terms of pharmacological, there's loads of things that they can give. So obviously start off conservative with NSAIDs, but it's important in rheumatoid to get started on DMARDs, which are disease-modifying anti-rheumatic drugs. So that's something important for SBAs to remember. In this case, yeah, NSAIDs are going to be helpful for the pain, but they're not going to stop further damage, so get them started on this immediately. So you're doing NSAIDs plus some other important DMARDs that we're going to talk about now. So you can split them into these three sections. So conventional, biologic, and JAK inhibitors are kind of on their own. So in terms of conventional, the first thing that you might have heard of is methotrexate. And how that works is by stopping folic acid synthesis. And what that does is decreases the activity of T cells. It decreases the activity of quite a lot of cells. It's pretty immune, like a pretty strong immunosuppressant. And it's one of those drugs that you want to know well in your OSCEs because you could be asked to counsel on them. So in terms of side effects, they're exactly what you'd expect if you're like suppressing the metabolic activity of a lot of your cells of your body. So myelosuppression, for example, hepatotoxicity, you get pulmonary fibrosis with the use of methotrexate as well. And the most common things, obviously, don't forget nausea, vomiting, rashes, like mouth ulcers, mucositis. That's methotrexate. So you want to be keeping a very close eye on their FBCs because of myelosuppression, LFTs because of hepatotoxicity, and then renal function as well. And the other thing to remember is this is not going to be safe in a pregnant woman or a man who's so either a pregnant woman or a man, really. Because folic acid, if you're inhibiting folic acid synthesis, that's going to be pretty damaging to a fetus, for example. And you also need to supplement with folic acid because that's going to be important in your body anyway, outside of methotrexate. Leflunomide. So I think the key thing, just remember the big picture, is these are some of the like common drugs, like the first drugs that you start off with. And maybe just have an idea briefly of how each of them works. Methotrexate you definitely need to know. Leflunomide, pyrimidine synthesis, you might remember this is another one of those components of DNA. So again, modulates immune response. So you're immunosuppressant again. Some of the same side effects, immunosuppressive, GI upset, rashes. That's leflunomide. Sulfasalazine, you might have heard in gastro as well, can be helpful. So this is a bit of an interesting one. It's both anti-inflammatory and antibacterial. Again, thinking something along the lines of stopping the activity of cytokines at the joint. Biologics, so these tend to be monoclonal antibodies. So you've got etanercept, infliximab, adalimumab. They inhibit tumor necrosis factor, which can be pretty strongly associated with RA. IL-6 is an acute phase protein. So for any new sites of inflammation, this is the drug tocilizumab. T-cell inhibitors, abatacept, again, anti-inflammatory. CD20 found on B cells, rituximab, also anti-inflammatory. So again, you can tell these are some really like specific drugs that a rheumatologist, depending on the patient or depending on their expertise, would be choosing. So key ones to remember, rituximab, because it crosses over into heme as well. A lot of these cross into heme, but rituximab comes up. Abatacept is a good one to know. But just briefly remember, these are some of the mechanisms: TNF, IL-6, T cells, CD20 B cells. And the other thing is JAK inhibitors. These are pretty much just things, like another pathway for inflammation to happen, the JAK-STAT pathway. So we're stopping cytokines from migrating to the site of inflammation. So key things to remember. These are the three different types of DMARDs that a rheumatologist might prescribe. They would start with conventional and then maybe pair them with a biologic or a JAK inhibitor, depending on how the patient gets on. And they have some side effects in common. for example, nausea and vomiting, rash and fatigue, like most drugs do. Myelosuppression and mucositis are pretty common amongst all of these DMARDs as well, because they're affecting like cells that multiply quite quickly. So these are some symptoms you might see. Contraindications tend to be the immunosuppressed, pregnancy, breastfeeding, because some of them can cross over, and be careful with hepatic renal impairment. So that's DMARDs like very quickly in a nutshell. But this is quite a nice way to think about it. So let me know if you have any questions as I move on as well. But just try and think about how each of these work. Where else have I seen these drugs? Yeah, and definitely for methotrexate, start thinking about how you'd counsel in OSCEs. Look at OSCE Stop. It has a good summary for some of the drugs you might need to know about. So now we can move on to some SBAs. If you want to join, I think you already have. I think that, where is the question? Here it is. Okay. So have a think about things we've talked about. Okay, now it should work. I'm sure you've already seen the answer, but let's see. Okay, it's not letting me do it, but this is a 28-year-old male who's presented to the clinic with 6 months of lower back pain and stiffness. It improves with physical activities, but it gets worse with rest, and it's really bad in the morning. His examination reveals reduced forward flexion of the lumbar spine and tenderness over the sacroiliac joints. And you've got tests that show a high ESR and CRP, and that's pretty much what they're giving you. So if we go through each of these options, ANA, we've said, is to do with vasculitis. This is pretty odd presentation, and it's more commonly seen in females as well. Bloods aren't giving you that much. You can't really differentiate between that. And the forward flexion of the lumbar spine and the sacroiliitis is pretty standard for ankylosing spondylitis. So out of these things, we're thinking something seronegative, and it's the only thing that's associated with HLA-B27 is the seronegative arthropathies. So ANA, like we said, we're not getting any of these other symptoms that we'd expect, like lung problems, nose problems. Rheumatoid factor. This is unlikely to be rheumatoid arthritis because of the joints that are affected, although the pattern of improving with physical activity it matches. Uric acid crystals in synovial fluid would be gout. Again, this is a weird place for gout to show up. Strange age range as well. We've got no history of a diet high in purines or like a kidney disease or anything like that. Unlikely to be gout. Anti-CCP for the same reasons, it's not RA. Okay, so I hope that one makes sense. Let's see if the next question. Oh yeah, okay, so let's go through ankylosing spondylitis. So that question was pretty much summarized everything, but you've got sacroiliitis, you can have chest pain, shortness of breath, because they get sort of a restrictive pattern in their lung function tests. Lower back pain, sacroiliitis. Those are the keywords to remember. And it gets better with use, like we know for most inflammatory arthritis. 5As, that's kind of a handy thing to remember. So anterior uveitis, you can have aortic regurg, you can have cardiac problems, so AV block. The lung fibrosis tends to be apical, and they can have anemia of chronic disease because, again, this is a systemic problem. Etiology, so this is an autoimmune seronegative arthropathy with an association with HLA-B27. And as well as genetics being involved, you've got immune factors, environmental factors, and that's going to be common for all of these seronegative problems. The diagnosis, it was a little bit in the question, but the forward flexion of the lumbar spine, there's a test called the Schober's test, and if the distance between the top of the ASIS and a marker above, sort of near the lumbar spine, if it's less than 20 centimeters, that means that it's restricted. And that suggests some sort of fusion is going on, which would point to ankylosing spondylitis. Bloods, CRP, ASR, because inflammation. X-ray, bamboo spine, and squaring of vertebral bodies. These can be quite late changes, as you can imagine. But basically just a really straight-looking spine, and they look quite close together as well. Management, you can use CRP-28. Again, you're going to be starting DMARDs quite quickly. Again, that's something a rheumatologist would do. NSAIDs will help with the pain. And this is the key cytokine here, IL-17. So this in psoriatic arthritis, these are the DMARDs you want to be using. Secukinumab and ixekizumab target IL-17. Okay. Let's see if this one works. Let me see if I can. It's not going to let me do it. Okay. Let's look at the question. You've got a 27-year-old male with 2-week history of painful swelling in the left knee and the right ankle, as well as redness in his right eye and dysuria. He recently recovered from an episode of diarrhea during his holiday abroad. So which of these is the most likely cause of his presentation? Do you want to put in the chat maybe what each of these is pointing to, each of these diagnoses maybe? For example, if we do crystalline arthritis, what would that be referring to? Brilliant, that'd be gout. Direct invasion of joint tissues by virus. Yeah, it could be septic arthritis, exactly. But this is probably reactive because we've got this triad going on of, you might have heard, can't pee, can't see, can't climb a tree. So dysuria, can't see, redness in his right eye, can't climb a tree, painful arthritis. And you've also got a clear preceding infection as well with the diarrhea after being abroad. So yeah, septic arthritis. We've not got any mention of a fever. And we've also got some extra-articular symptoms, which you're not going to see in septic arthritis. Crystalline, so gout, again, 27-year-old male, unlikely. Lack of a past medical history pointing towards reasons for more uric acid or calcium. And you've got problems with multiple joints, so again, gout, unlikely. Primary autoimmune connective tissue disorder. This is only a 2-week history. And why did they mention that he had diarrhea during a holiday abroad? Because that wouldn't be related to something like a primary autoimmune disorder. Direct invasion of joint tissues by a virus. Again, acute onset. You're not really going to see any extra-articular things going on. So this is the pathophysiology for reactive arthritis. So same inflammatory cause, pain, stiffness, the triad that we talked about, as well as sometimes you can have oral ulcers or specific types of rashes. The etiology here, this is important, is it's actually completely sterile. It's the immune complexes of the antigens against the bacteria, that are causing synovitis. It's not that the bacteria are depositing in the joints and causing a problem. It's not an infection. Autoimmune, again, HLA-B27. And these are some causative organisms that are important to know because they could ask you, a particular demographic that might be more at risk of certain types, certain infections. So if you've got a history of diarrhea, you're thinking along these lines of enteric bacteria, either gram-positive or gram-negative. Um, for a young sexually active adult, and no mention of diarrhea, could still be reactive arthritis, could be due to some sort of STI, chlamydia, for example. The diagnosis here is a diagnosis of exclusion pretty much. You're going to aspirate the joint and they'll be negative. Their white cells might still be up because they had an infection previously, but when we're getting sterile fluid, management tends to go away on its own, NSAIDs. And I've never seen in a question that you need to use sulfasalazine or methotrexate, but you know that it's just something to keep in mind. Okay, another X-ray. Any ideas of what this might be? Arthritis mutilans, that's really good. That's really specific as well, and pretty much the answer. So it's psoriatic arthritis. So we're seeing this really, really specific sign called a penicillin cup deformity. I've got a better picture here of what's going on. So it's destruction of the cartilage and the bone, and it causes like this sort of picture where the the more proximal bone is going into the more distal bone. You might see that on X-ray. You can see it a little bit here. Dactylitis, that's swelling of one individual like finger, like a sausage finger. You might see that on X-ray as well. Arthritis mutilans you mentioned, which is just really severe joint destruction. So that's psoriatic arthritis. And this is a good one to pick up. You get nail changes as well. You get psoriatic plaques. And that helps you get the diagnosis. So inflammatory course, psoriatic skin changes we talked about. Know what each of these words means. Plaques, you know, nail pitting, we talked about. Dactylitis, sausage finger. Onycholysis, like lifting, like in fungal sort of look to the nails. Enthesitis is inflammation of where the tendons insert into the bone, so that's enthesitis. Deformities, really severe changes, DIP joints and axial skeleton. Those are the areas that you usually see affected in psoriatic. Etiology, again, HLA-B27 associated. Diagnosis could be clinical, could be using an X-ray if it's really late stage disease. Management is again standard. NSAIDs, you've got your classic use of conventional DMARDs, and then move on maybe to biologic therapies. You can target these cytokines as well as IL-17 as well. Okay, let me see if I can show you the question rather than the answer. No, I can't. But anyway, so you've got a 58-year-old man presenting with chronic joint pain. He's got lots of swelling. He's got nodes forming on his hands and his feet. He has a strong medical history of hypertension, CKD, diabetes. And the nodules are over his elbows, his hands, his Achilles tendons. His uric acid, serum uric acid is raised, serum creatinine is raised, which we expect for a CKD. His GFR is low, and we aspirate the synovial fluid. We see needle-shaped, negatively birefringent crystals. So which of these is the most appropriate long-term management? So what are we thinking the diagnosis is here? Brilliant, it is gout. So what's important here? This is actually quite a tricky question. Does anyone have any idea why we've started febuxostat? If I show you the rest of these options. Okay, so thinking something to do with cardio damage or renal is good thinking. Renal is the right answer. So he has a CKD. Um, and we can't have NSAIDs. We can't use NSAIDs or colchicine in people with kidney damage. So febuxostat is literally third line in acute management. Um, and it can be handy to know how each of these works. So we'll go through each of these drugs anyway. So start colchicine. Colchicine is it affects how your neutrophils work. So it prevents the formation of microtubules in your neutrophils, so anti-inflammatory. Renally excreted, so not safe to use in CKD. Febuxostat is a xanthine inhibitor. So it's a good one for long-term management. Perform joint aspiration and use an injection. This isn't indicated in gout, and you don't need to insert steroids. Start allopurinol. So this is contraindicated in renal impairment, although this would be first line for long-term management. Advise lifestyle modifications, avoid pharmacological therapy, not going to be helpful in gout. It's not going to resolve itself. So summary, gout, very severe pain, and it comes in episodes. It's normally of the first MTP, so that's your like big toe, and that's called podagra, or it can be ankle, wrist, knee. You might see gouty tophi like we saw in that question, and the history tends to be things that point towards like things that accumulate uric acid, high purine diet, cardiovascular, renal. Etiology is the urate crystals. You can diagnose the serum urate might be high. Monosodium urate crystals are needle-shaped and negatively birefringent. They might give you a picture. This is what you might see. Important to know what this looks like versus pseudo-gout. The X-ray, these are some buzzwords. So lytic lesions, punched out erosions, sclerotic borders, because the uric acid is like biting. Management, this is important. In an acute flare, you want to be using these drugs. So NSAIDs or colchicine or oral steroids. Think about renal impairment. Think about what you'd use in that case. Prophylaxis you initiate immediately after the first flare. So as soon as someone has gout, give it a few weeks, then start them on either allopurinol or febuxostat, which both inhibit xanthine oxidase, which is an enzyme that leads to the production of uric acid. Okay, any ideas what this is? Brilliant. Pseudogouts, we're seeing rhomboid crystals. They're positively birefringent. But think about the previous one. Colors are more bluish in these positively birefringent crystals. And what we're seeing here is calcium pyrophosphate. This is not uric acid. So that's what differentiates pseudogout to gout. Normally it affects the larger joints. We'll go through the summary slide. But yeah, treatment, NSAIDs, colchicine, glucocorticoids. No point in using allopurinol or febuxostat because it's not a uric acid problem. Okay. So 72-year-old woman with acute pain, swelling, and redness in her right knee. The symptoms started 2 days ago, suddenly. No trauma to the joint. And she has a history of type 2 diabetes, hypertension, and CKD, stage 3. She has a warm, swollen, and tender knee, positively birefringent rhomboid-shaped crystals. What's the most appropriate next step in management? So again, person with CKD, so what are we thinking we should do? I know it says the answer, but can you explain why maybe? And we've also found out that she's got white blood cells in her synovial fluid. So it is pseudo-gout. Okay, so that's exactly it. So you're not going to be using corticosteroids immediately. We've not tried anything else yet. Allopurinol is prophylaxis in gout, has no role in pseudo-gout. Empiric intravenous antibiotics. You've not got any signs that this is something to do with septic arthritis. She's afebrile. NSAIDs, CKD, so we're not gonna prefer NSAIDs. So colchicine. So pseudo-gout, severe pain, swelling, erythema, pretty similar to gout, but can be milder. Same sort of location, but you're not normally going to see it in the like the first MTP. History of some of these conditions that might cause high calcium. Etiology is calcium pyrophosphate crystals deposit in joints. So this is important to know because there's loads of like calcium compounds that come up in medicine. Calcium pyrophosphate is what we're thinking about in pseudo-gout. Diagnosis, again, joint aspiration, X-ray changes. You rarely get asked about these osteoarthritic changes, although they're possible. Chondrocalcinosis is a keyword that could come up. And management, like we said, NSAIDs, no for CKD, colchicine, okay for CKD, oral steroids, third line, intra-articular steroid injection. I've never heard of that being used, so yeah. So really important topic to know how to differentiate between them. In terms of etiology, so gout, these are things, so you can split it up into things that cause reduced uric acid excretion versus increased uric acid production, which would be part of your tumor lysis syndrome. Problems with your kidney, can't excrete uric acid, hypertension, use of thiazide diuretics retains uric acid. So those are some of the things to look for in the history. Hemochromatosis, hyperparathyroidism, or idiopathic is the most common cause of raised calcium pyrophosphate. So that are some of the high yield etiologies. So our patient now has fever and swelling in her knee. So any ideas of some of the red flags that you might see in joint pain? Some things that might come up in an SBA that you'd immediately think are bad news. Yeah, bone pain is a good one. Neurovascular status, good one. Those are pretty high yield. Pain out of proportion, yep, compartment syndrome. Good. Monoarthritis, some of the things that we covered before, if you think about it like a vascular pathology, um, gout, any of these things, if they're left untreated, can be quite damaging to the joint. Um, thoracic spine pain. So this, if you think about it, is a pretty strange location to get pain. Points towards some sort of etiology with the bone itself, like malignancy, for example, because you don't really use your thoracic spine that much. And like you said, pain out of proportion, thinking compartment syndrome. Okay. Um, let me actually like copy and paste the question because I want you to give it a go. Um, okay, here we go. So 72-year-old woman with pain, swelling, redness in her knee. She has osteoarthritis and recently had a hip replacement. She has a fever, tachycardic, knee is erythematous, swollen, tender, reduced range of motion, elevated white blood cells, and joint aspiration reveals cloudy fluid with, again, high white blood cells, predominantly neutrophils. What's the most likely cause of this patient's condition? So IND and MSK combined. Okay. Give you a few more seconds. Okay, brilliant. It is Staph aureus. So if we look at the options, gonococcal, so Neisseria, we talked about for reactive arthritis, it's the same demographic, tends to be the younger sexually active adults who are getting that kind of infection. Again, also not really that common to cause septic arthritis. You more see it in reactive. Staph aureus, that's pretty common commensal. Could be introduced, for example, if you're having like a hip replacement. So that's the most common. Um, Tuberculosis, we talked about Pott's disease, so affects the spine more commonly, immunocompromised or people from the endemic regions. Salmonella, we talked about for sickle cell patients specifically. It's not the most common overall. And rheumatic fever, it's more a pattern of migratory arthritis. So you get all of those systemic signs of an infection, but it's more likely to be in a child. They've had some sort of sore throat. That's the picture that you'd see. Treatment would be empiric antibiotics, joint aspiration to confirm the microbe in there and the sensitivity, and vancomycin tends to be what you give for gram positives. Ceftriaxone has good coverage for gram negatives, but again, this can differ based on hospital guidelines or whatever the drug is. But that's just how I like think about it if you want to just go for the most high yield antibiotics. And very important if there is a prosthesis to get it out. Okay, let me again, give me a second, I'll get this question up. So it's going to be the last SBA that we do. So we've got a man with 2-month history of progressive hip and shoulder pain. It's aching and it's worse at night and it disrupts his sleep. He also has some weight loss and fatigue. Past medical history of hypertension, lots of smoking, 50-pack years, reduced range of motion, mild tenderness, but no swelling or redness. X-ray imaging shows some joint space narrowing and patchy bone sclerosis. So what is the most likely diagnosis? So this is RESP and MSK. I'll give you a few more seconds to think about that. And think about which of the things in his medical history you've mentioned would give you the answer. Okay, I've got some answers. So a lot of you said metastatic small cell lung cancer, which is a really good differential. And that's pretty much why I put this question in, is because there's so many different lung cancers. But the most common, as well as the strongest association with bony metastases, is adenocarcinoma. I know that he has significant smoking history, 50-pack years. But that's outweighed by the fact this is a bony metastasis of the lung primary. For small cell lung cancer, you'd more likely see like symptoms of ADH being high, Lambert-Eaton syndrome. For squamous cell carcinoma, you get like a high PTH, so hypercalcemia, local invasion, more likely. Osteoarthritis doesn't explain weight loss or fatigue. SLE, there's no skin changes, no, not really an inflammatory picture either. So this is a really tricky one. Adenocarcinoma, most common overall, even though we've got a significant smoking history that was supposed to throw you off a bit. So malignant bone lesions, you've got your lytic lesions. So here we had sclerosis. Lytic lesions, these are some of the primaries. So multiple myeloma, non-small cell, so squamous, renal cell carcinoma, and you're seeing these punched out lesions. For sclerotic lesions, the adenocarcinoma, like we talked about, so that's another reason that it's not going to be squamous cell. Adenocarcinoma, prostate, breast commonly metastasizes to the bone. Mixed could include thyroid as well. They're not really going to give you an X-ray to look at and diagnose it straight from that. But just bear in mind like how which cancers metastasize to the bone most commonly. So prostate, breast, and lung are the most common. Then you've got some other keywords you might hear. So, for example, if you hear onion skin, think Ewing sarcoma or osteosarcoma. More commonly Ewing's. If you're seeing like a sunburst appearance, think osteosarcoma. And this is a summary of what they might look like. Again, really unlikely to give you an X-ray, but it might be helpful just to know what they look like. Any questions? I know that was quite long. My sound was cutting off. I hope it sorted itself towards the end. But some next steps for you. So definitely learn your joint examinations. If you want to look at bone imaging and practice how you report that, use radiopedia, especially for fractures, and try and get a system. For management, it's usually stepwise, but there are going to be times where you have red flags that you really need to know how to step straight up to that management. Even for rheumatoid, remember, start your DMARDs very early on. And PassMed and Geeky Medics are really good just to know how you like how a patient might present, and you get really fast at diagnosing. So yeah, that's pretty much all I wanted to say. So if you've got any questions, I'll hang around for a bit. Please fill in the feedback form as well.
Hi, thank you so much for the tutorial. It was really, really useful. I had a few questions just about pseudo gout and gout in terms of treatment.
Yeah.
So you mentioned for like allopurinol